we could relate this to maybe an English class a little bit. So if we start out with just the terminology telehealth in a crisis, that leads you to believe that telehealth is in a crisis right now. And it may be a crisis of good fortune that everybody wants to do telehealth, but I certainly don't think that telehealth is in a crisis at this moment. And then if you put the emphasis of screaming telehealth in a crisis, um, again, I don't think that telehealth as a technology, as a facilitator of clinical services is in a crisis right now. In fact, it's funny, I talk to people that are kind of my peers around the country, and we now are saying, gosh, be careful what you ask for. We probably for years and years and years said, boy, I wish something would happen that would kind of elevate telehealth. Well, we got it. And then finally, what I think is really happening, what we're going to talk about today, is telehealth operating within a crisis situation. And so, as you see in these 3 slides, punctuation matters. So for the agenda today, we'll talk a little bit about what is telehealth and why telehealth. We'll talk about legal and regulatory considerations and other considerations. And then finally, we're going to talk about March 2020. I don't think healthcare is going to ever be the same. And I certainly know that telehealth is never going to be the same. Okay, so really simply, what is telehealth? And my guess is that if we knew everybody that was in the audience today, there are probably some of you that are highly literate telehealth and do it all the time. And then there are going to be other people that, this may be, one of your first experiences with telehealth. But really simply, telehealth is using communications technology to get the right care to the right people at the right time in the right place. And maybe as importantly now as any other time, for the right price, because healthcare is in trouble right now. I mean, I dare say every healthcare facility is struggling because we're all trying to scale back what we do to prepare for some kind of a surge of patients. And what that means is that all the elective procedures, all of the traditional clinic work that we've been doing has to a great extent gone by the wayside. That's significant revenue opportunities that we all face, and those are gone right now. John and Jerome, I'm not sure you can hear it. I'm picking up a little bit of feedback. I don't know whether.
Yeah, I'm hearing the same thing, Rob. That's a little bit of an echo, right?
Yeah, that's fine. And we'll keep going, but just wanted to check.
Did not hear an echo.
I don't hear it now, so I think we're good. Okay, so why telehealth? It sure looks cool. Man, this telehealth will look great on my resume, or maybe you saw it on last week's episode of New Amsterdam. And again, let's say prior to March 2020, your boss probably has been saying, when are we going to do this telehealth stuff? Or when are we going to do more of telehealth? And then there was always a concern that we're not going to be able to keep up with other practices, that we're going to fall behind in care delivery if we don't do telehealth. None of those are really good reasons why to do it. It should simply be a tool that fits in your strategic plan. both from a care delivery perspective and also from a financial perspective, because um, as we have found that as the world has changed over the last couple months, um, the demand from patients has changed significantly. And so and we'll talk about that to a great extent. So why telehealth now? COVID-19 changed everything, and we have got to adapt to it. Um, I'm pretty sure that UK is not alone in this. That again, and I think that the larger hospitals probably feel um, more pressure to kind of clear space within the hospital to make sure that ICU beds are available, um, and that acute beds are available, because if and when there is a surge of patients, we've got to be prepared for it. And I think what you find is that most hospitals are being incredibly conservative with this. So, um, stopping um, stopping elective surgeries weeks and weeks ago, everybody knew that that would take a hit on the bottom line, but they did it because if and when the surge occurs, we would probably rather err on being conservative than say, well, geez, we've got a whole hospital full of patients that had elective surgeries, and we're not going to have room until we clear them out. So I think what you find is that hospitals all over the state were incredibly conservative to prepare for this. There are legal and regulatory considerations, and if you've been doing this for any time at all, they're pretty familiar to you. Reimbursement, licensure, privilege and credentialing, privacy, confidentiality, security, anti-kickback, the Stark self-referral rules, and the medical malpractice and liability. We'll touch on these just a little bit. For anybody that has done telehealth for a period of time, that for many years, reimbursement was the real challenge. That telehealth could not achieve its potential because the providers could not get paid for it. And we started telehealth in the mid 90s in Kentucky. No payers paid for any telehealth services, and so back then it was grant funding and external funding that paid the providers to do this kind of work. What you saw over the period of time was that Kentucky was the first state in the country to have mandated Medicaid and commercial health plan reimbursement. And that was a legislation that passed in 2000. And then legislation that passed in 2018 went into effect in 2019, actually put Kentucky way out in front of many states in that we have true parity for telehealth. So if a provider, a Medicaid or commercial health plan provider gets paid for doing telehealth or gets paid for a healthcare visit in a traditional in-person ICU, you see me in a clinic visit, that same clinical encounter is going to be paid for by telehealth. Um, Medicare is still lagging behind a little bit. Medicare has some rules that we certainly don't agree with, but have lived within the constraints of, and not the least of which is that Medicare historically has mandated that the patient be seen via telehealth while that patient is physically in rural America. And the patient also has to be at a healthcare facility. So the home was not, according to CMS, according to Medicare, not an appropriate place for the patient to be seen for a telehealth visit. Again, things have changed. Licensure was another issue that we've had to deal with. Just because telehealth makes it easy to cross state licenses or to cross state borders, it doesn't mean that that is an appropriate use of the technology. And so historically, licensure has been a barrier in that the place of service is where the patient is located, not the provider. And so it was very important that the provider be licensed in the state where the patient is physically located at the time of the encounter. Some people have worked around that by getting licensed in multiple states. We'll talk about that in just a second. Privileging and credentialing has been an issue that I feel has largely been overcome, mainly because the Joint Commission and CMS have approved delegated privileging and credentialing by proxy rules. And so that allows a community healthcare facility to essentially take the larger healthcare facility's word for the privileging and credentialing of a provider, essentially saying, look, if you are credentialed at Appalachian Regional Healthcare or UK or Norton or U of L, well, that's good enough for us, and we will accept that from our medical staff. And so that's been a great help in that realm. Privacy, confidentiality, and security have been a huge issue always. I mean, you can imagine that if you do healthcare through any kind of technology, that those are going to be an issue. And even post um, the COVID-19 issue, issues of privacy, confidentiality, and security using telehealth have been all over the news. And so a lot of people have seen um, some of those stories, and we'll talk about that a little bit. The anti-kickback stark self-referral that, no matter what happens, you can't give equipment to somebody as an inducement to refer patients to you. And then finally, medical malpractice and liability. This has been a really interesting subject, and I appreciate, and I am so fortunate at the university, we have a legal team and a compliance team that stays on top of these things. But this refers straight back to licensure. Lots of people have gotten licensed in multiple states in order to facilitate telehealth. The problem is that they may not have expanded their medical malpractice insurance to those states. Um, and, and especially from an academic medical center like UK, if our providers practice outside the state, we are subject to losing our sovereign immunity protection. And so it's very important if you decide to cross state lines that those are something that you consider, not just the licensure. So those are the legal and regulatory considerations that we had going into this disaster. And then March 2020 happened. And suddenly these things changed significantly. And again, these changes are happening by the day. I got to tell you, I can't keep up with them. Thank goodness we have a very active compliance and legal and regulatory team at UK that does that. But if we touch back on some of those legal and regulatory issues, we can talk a little bit about how things are today post March 2020. The reimbursement rules have been pretty significantly relaxed, especially from Medicare. So with Medicaid and commercial health plans, we had parity in the state. Now, just because we have parity in the state doesn't mean that you don't have to fight for reimbursement, because we have seen some commercial health plans that have, they haven't been as upfront and forward as we would like for them to be. The legislation is clear. You will pay for telehealth visits. What some of them have done is try to put caveats like, well, you have to use our own proprietary platform. That doesn't work. That does not say anywhere in the legislation. So there may be times that you have to argue for reimbursement. The licensure rules have actually been relaxed. The cross-state licensure or cross-state practice of telehealth is becoming pretty common. And But what's most important, and I'll refer you back down to the last bullet point, is just because it says you can do telehealth across state lines doesn't mean that your medical malpractice and liability is waived as well. Because if you practice in Tennessee, you're practicing under their rules and regulations. Um, you are held liable and accountable for their medical malpractice issues. So, um, as a whole, the University of Kentucky has decided that we are not going to practice across state lines using telehealth. Not that you shouldn't, but that you should work really closely with your compliance and legal team, make sure that you have all your bases covered. Privacy, confidentiality, and security, the rules have been significantly relaxed. But HIPAA still applies. I mean, some people have come out and said, well, HIPAA doesn't matter anymore. Well, yeah, it really does. But there's been a great relaxation of the rules. And in fact, it has prompted people to be able to try some things. I think probably one of the things that is most relevant here is that, if you have a problem, if something happens that patients bump into each other. We'll just use that as an example through the technology. You report it and you explain what happened. You mitigate it as best you can. But I think what you'll find right now is that the rules have been relaxed a bit. The anti-kickback and the Stark self-referral rules, there have been no new guidance. So again, this is not going to open up the doors for you to put equipment in a community healthcare facility as an inducement for referring back to your providers. So some considerations as you develop telehealth. And these are some issues that we have dealt with University of Kentucky, and I've talked to some other people around the country of things that they're doing and considerations that they have. So providers, staff, and patients want to limit the exposure. The fewer times that people have to come in contact with each other, the better. And you think about the PPE usage, again, PPE is in limited supply. And yet, do you really want a provider walking from room to room to room to room in the same PPE? I mean, they just become a vector for whatever it is that's out there. And the other issue is patients don't want to come to clinic. I mean, I don't know if anybody has looked at if you have an ambulatory setting within your organization, but if you looked at the numbers for a day or 2 days or 3 days after some of these rules came down, where people really began to take this seriously. I mean, we saw, day after day after day, 20 to 30% drop off in patients coming to clinic, where we eventually got to where we were seeing 60, 70, 80% less patients were physically coming to clinic. There is certainly a need to reduce unnecessary ED visits. And again, I don't know whether you've seen it in your facilities. I suspect you have, but it is shocking to me how less busy the emergency departments are right now. I mean, people are really taking this to heart, not wanting to come to the emergency room. There's a great need to move stable patients from the hospital to home and possibly to do monitoring for those patients so that we can free up beds for more severe and for the COVID-19 patients. We consider telehealth within the hospital facility for inpatients, and again, just to reduce the exposure to more and more clinicians. We need to reach patients where they are, and right now, patients are at home. I can tell you within the last year or two, UK probably, we didn't do more than a couple hundred home-based telehealth visits a year. Mainly one of the reasons why it wasn't reimbursable to a great extent. And what we have found in the last month, in the last 30 days, we've done over 5,000 home-based telehealth visits. So it, again, the model has completely changed. We've got to be flexible based on the patient's technical capacity. I mean, there are going to be patients that don't have a smartphone, don't have a tablet, don't have a computer, don't have appropriate broadband, or if they do, they may not have a data plan on their smartphone, or they may have a limited number of minutes, and we need to be flexible based on that. And probably the toughest thing is that we got to do it now. Like, I'm sure that the pressure has been put on you guys that this has to happen now. And so making those kind of significant decisions about something like telehealth is tough when you're under that kind of a time restriction. So what's the future of telehealth going to look like? And the future is now. It's going to look like that smartphone. Um, I feel confident in this, that what we're seeing, and I've really been surprised at the number of patients that are using their smartphones and very literate with their smartphones. And it's not just people in Louisville and Lexington and Northern Kentucky, is people all over the state, urban and rural, young and old, are remarkably adept at using their smartphones. In fact, one of the clinics we have is a neurology clinic for older patients that have dementia that are being cared for by their by a spouse or a loved one. And when we contact these people to move their visit from a traditional in-person visit to a visit through Zoom, through their smartphone or computer, the patient's family is like, oh, yeah, we use Zoom all the time. That's how we go to church. And so what we have seen is that the world just turned upside down. And now we have people that are adapt to doing this because this is how they do church now. Providers must be able to connect from any device. Patients must be able to use any device. And the legal and regulatory rules must support this new practice. I tell you, the challenge, and when you talk about compressing the time, is this vendor selection. What's right for your practice? I talked to a CIO of a small Kentucky community clinic, and when they finally saw that the um, ambulatory visits just cratered, where people stopped coming into the clinic, they made a decision in one day that they moved their patients that weren't going to be able to come to clinic to phone calls. And within 2 days after that, were able to move these patients to video calls. And so they quickly bought a platform that did telehealth and were able to deploy it literally in 3 days. It was, I mean, I thought what we did was pretty quick, but what they did was just extraordinary. Some of the problems that we have to consider is that traditional telehealth required patients to go to another facility. Well, they may not want to come to UK, they may not want to come to your hospital or clinic, but they don't want to go to their community-based clinic to connect either. So again, we've got to reach people at home. Again, we said some people don't have the technology or the broadband, and we have to work around that. But what we have found, often found, is that if you call a patient, they go, well, I don't have a smartphone, or I don't have appropriate broadband. If you ask the question, do you have a family member that lives close to you that does, they'll often say that they do. And it could be a 14-year-old kid. It could be the grandson or somebody, but there is usually somebody that has the technology available. And then how do you do this quickly? Do you look at a technical solution that is designed for individual providers, or do you look for an enterprise platform? How do you keep up with the changing telehealth environment, especially the legal and regulatory? And then what happens after COVID-19? I think this is really intriguing, because when you look at the changes that have taken place from a legal and regulatory perspective, I don't think we can walk it back after COVID-19. I think that the demand is there. I think that the outcry for this kind of technology is there. I think the providers and the patients both have begun to recognize what can be done with really simple technology. And I think it's going to be hard for Medicare to walk this back and say, okay, we're going to go back to the way things were before March of this year. So what's being done in Kentucky? Acute primary care via telehealth, coughs, colds, the simple things that people would normally just go to a primary care provider for, or maybe go to the little clinic or an urgent care center. They're able to do this through telehealth. You're able to convert traditional scheduled visits to telehealth. And what we have seen at UK is that every department, every division, every clinic has deployed telehealth and is going back and calling patients that were scheduled to physically come and ask the question, do you plan to come? And if they did still plan to come, they would assess whether that was really the smartest thing for the patient. And they would then convert most of those patients to a telehealth visit. It was really important to know that if video is not possible, that you can default to audio only. And an audio only call may not be as clinically appropriate, but it's something, and there is some minimal reimbursement for audio only calls. You're seeing more and more people doing telehealth within the emergency department, trying to reduce the number of clinical contacts that people are making. We're doing some work with inpatient consults. We've seen that in other hospitals, again, trying to reduce the amount of face contact between a patient and a provider. Care planning with distant family, we are seeing this done, say for a patient with a stroke patient. And what we have seen is that in some cases, decisions about palliative care or even stopping heroic care are being made through the technology when the family can't physically get to the hospital. And in some cases, the rules on visitors have been highly restrictive, and in some cases the patients can't come see the family can't come see the patients. We've seen something called e-rounding, where at the beginning of the day the entire care team goes from patient to patient, and what we're seeing is that, and what that usually results in is mass use of PPE as a whole group of people come into the patient's room. And then also there is contact between all those providers. Well, using e-rounding, there literally one person is standing outside the patient's room with a tablet or a computer, and they're able to join an entire care team together without having them all be together at one time. We're seeing early discharge from the hospital with home monitoring to make sure that the patient is trending well. And then as we get to questions and answers, I'm going to be really interested to hear what you guys have seen. So what have we learned in this time? I mean, we've learned flexibility. We are nothing today if we are not flexible. I don't know about you guys, but I found I can be pretty darn productive at home. I think our generation could be the one, and it's not just, the Gen Xers, the younger people, it's folks like me that have found that I can send my people home and we can be productive. Not every patient has to come to clinics. And again, I've been incredibly surprised how flexible patients are, how many of them have the technology. Can we ever go back to pre-COVID? I just don't think so. I think the patients and providers are getting a taste of what this is like. The challenge is going to be, will the regulators take us back to what it was? And that there were a couple questions that were submitted previously that John and Jerome sent to me speak about the patient consent process. Let me just tell you what my team has told us is that we email consent form to the patient, a traditional consent, as well as a telehealth consent. Um, and we are in a place where we're able to do verbal consent. So we ask the patient, did you get the traditional consent form, the consent to treat, the HIPAA forms, as well as the telehealth consent form? And we ask, do you have any questions? And if need be, we'll go through it with the patient, but then we consent them verbally through the telehealth visit. So we're not having them take photos and send it back. We're not getting a signed copy back to us. We also ask the patient, are you physically in the state of Kentucky right now at the time of the visit? Because if we don't confirm that, we are, we conceivably could be liable for practicing out of state without a license. Now, the patient can always lie and go, yeah, I'm in Kentucky, and they could be at their grandma's house in Tennessee. But we just feel compelled that we have to ask the question and document that we asked the question and that the patient said that they were within the state. We've got another question that said they've heard some programs are hosting tumor boards using WebEx and Teams. I'm embarrassed to tell you, I don't know whether they're HIPAA compliant. I can tell you, HIPAA didn't, we talked about it, it didn't get thrown out. Like HIPAA is still out there. There has been some relaxation, but I want you to be safe with it. And so I would talk, do your due diligence, talk to your legal team. But there's actually some CMS ruling where it kind of, they specifically mentioned things like FaceTime. I thought they mentioned Teams and WebEx. I'm not sure, but we could certainly try to look that up for you. But it's not terribly hard to research that. Okay, guys, that's. I think I left about 20 minutes for questions and answers. If you guys want to take it on.
Okay, I have a couple of questions already. One is, can a patient get prescriptions filled via telehealth?
Absolutely. Yes, they can.
Okay.
Not sure how far to take that, but yes, that's done pretty commonly.
Okay, this one I believe you covered, but I'll ask it anyway. Where can healthcare providers conduct telehealth? Do they have to be at the facility or home?
No, they do not. So we have providers that are doing this from home. Again, secure, private. You don't do it at Starbucks. So those are the issues you need to consider.
Okay. Felicia just sent a comment that the American College of Surgeons will have a WebEx on Thursday regarding virtual tumor boards. So that would be great. Felicia, if you can send me that information, I would definitely share it with the affiliate network. Okay, another question. I need bifocals, folks. Let's see. Are there any insurances that you know of that do not cover telehealth visits?
Okay, so in Kentucky, Medicaid and all commercial health plans are legislatively mandated. They have to pay. Now, I can tell you, I won't call them out right here, but there are a couple that say, well, yeah, we do, but you have to use our specific platform. There's nowhere in the legislation that it mandates that. And there's really no legal precedent for that. So we may have to argue the point, but there's no reason. And then Medicare, and again, with the relaxed rules that you have right now with Medicare, they essentially will pay for telehealth, whether the patient's at home, It doesn't matter where they are. So at the moment right now, just about everything you want to do is reimbursable.
Okay. Is there a toolbox for telehealth if a facility does not currently have a telehealth program?
Uh, um, I'm not sure what's out there. Everybody has their own models, but I don't know if there is a, I'm not sure there's, now what I can tell you is that the telehealth resource centers for Kentucky, the Mid-Atlantic Telehealth Resource Center is a great wealth of information. So you may want to do a search on MATRC, which is Mid-Atlantic Telehealth Resource Center, and they should be very helpful for you.
Okay, two great questions. How are providers using telehealth services with patients who need an interpreter?
Well, all I can describe what UK does. That we have it included in our contract with our interpretive services. Now, we do that several different ways. In some cases, it may be just through a speakerphone. In some cases, we have a lot of our interpreters that do their work through a tablet. And in some cases, the provider can just bring the tablet into their office and do the interpretive services. And there are some interpretive services that'll literally jump in on your video conference call. Now, ours does not do that right now. But yes, there is, and frankly, you're mandated, whatever service you offer, you have to have interpretive services included.
Okay.
Now wait a minute. Before
okay.
you ask another question, I am shocked that nobody has brought up the term Zoom bombing yet. Come on, people. Has anybody got it yet?
No, but I've heard where people have hacked into Zoom meetings before.
All right, let's touch that. Let's touch on that before we move to the next question, because we are a Zoom shop. UK uses Zoom. We're using Zoom right now, but we use Zoom for clinical services. You will hear not just Zoom, but other platforms say, well, we're HIPAA compliant. And what we have discovered over time is there is a difference between HIPAA compliance and secure. And Zoom bombing is that example. So if you've ever heard the term, but you may not know exactly what it is, at the end of every Zoom web link, there is a 9 or a 10-digit number. That is your Zoom ID. And if you know somebody's 9 or 10-digit number, and they do not have some security protocol in place, you can call right in on the meeting. And there have been some, first of all, these are people that have way too much time on their hands. Because if you think of a 9-digit number, that is 1 billion number combinations. A 10-digit number is 10 billion number combinations. When you think of both of them together, Zoom has 11 billion number combinations. And what people are doing is just typing them in one after the other until they hit a meeting. Zoom bombing is a problem. We have not seen that problem because in our clinical services with Zoom, we use something called a waiting room. And I think most of these platforms will have something comparable where if you, like today, if you were to call into this meeting, Jerome as the leader would have to admit you into the meeting. So you don't just pop up on screen and see us. You would literally sit in a waiting room and it would say, you must wait for the host to admit you. So you don't hear anything, you don't see anything. You are prompted to type your first and last name. And so Jerome as the leader would look at the meeting at the waiting room and say, oh, there's Rob Sprang. That's my 1 o'clock appointment. I will admit him, but there's 3 or 4 other people out there. I'm not admitting any of those people. So that's the issue with Zoom bombing, but do not let that dissuade you from using Zoom if you feel that's the platform for you, because our experience is that at least it's worked really well for us, but there are lots of good platforms.
Okay, now continuing with the questions. What happens if a visit is disconnected due to connectivity? Do they have to reschedule? And to piggyback that, someone asked, do they get reimbursed if they're disconnected?
Yeah, look, this is a practice decision that you'll make. Uh, we have had people that, okay, so if they disconnect, you can prompt the patient to try to reconnect. If they can't reconnect, you may reschedule them. You may decide, well, I think I can manage the rest of this through the phone. So you have your options. I think most practices would say if we got disconnected, we're certainly not going to charge for it. And what we have seen many practices do is that if you have a visit and telehealth is not appropriate to make a clinical decision, that the clinical practice will say, we're going to reimburse you for this visit because you're going to have to come in here and see us. But that's a clinical practice decision.
Okay. Can telehealth be used for the initial visit or a new diagnosis?
Yes, it may.
Okay. In order to qualify for reimbursements, would we have to create a new telehealth component in our EHR?
That's going to have to be a practice decision. What we did, I know what UK did is we created the telehealth note. So there is a unique telehealth note when a provider sees a patient. So I would think that most of you are going to want to create a telehealth instance in your EHR, if for no other reason than to track it. But you also want to make sure that you have set guidelines in place, because there are billing requirements. Today, you're going to you don't use a modifier, but you use a place of service code 02. There are rare occasions that you use the modifier, I want to say it's 95. But yes, I would highly suggest you create a telehealth instance in your EHR.
Okay. Oh, a question I may be able to answer. Will this be saved, and will you send out PowerPoints?
Oh, sure. Yeah, if you want, I'll send it to you and you can decide what to do with it.
Yeah. Right now, I'm currently recording this session, and it will be available in our McCann Resource Portal, and also through Markey Cancer Center. Rob will send me the PowerPoints. They will also be available through the McCann Resource Portal. Let's see. Okay, one more question. How do patients pay their copay through telehealth visits?
Ooh, that's a good one, guys. And we don't have a good answer for that. So there are platforms. There are highly sophisticated, highly expensive platforms that include all of that together. Now, in some cases, and this is something really important that you guys need to consider, is whether your electronic health record has an integrated telehealth component or a video component, because sometimes they have that available. If it does, then you can do that through your platform, and they often will have the ability to take credit cards and copays. At UK right now, because we don't use one of those, and the platforms for things like Teledoc and American Well and MD Live, and there's hundreds of them out there that has an integrated credit card capability to take payments. We bill people for the copay. And I think we recognize that collection will probably be less than optimal, but that is the plan that we have right now.
Okay. If there's no more questions out there, and I just sent an email out to solicit more, doesn't look like we have any more, I would like to share what's coming up for the rest of the week. So right now for this week on our COVID-19 web series, we have a video that's already out there, and that's on health equality amid COVID-19. Thursday is our Cancer Care in the Times of COVID with Dr. Rima Patel, and that's at 1:30 p.m. So I will be sending emails out, just reminding everyone of those events coming up. Once again, this is currently being recorded, and if you need access, if you're an affiliate member and need access to the resource portal, please send me an email at jeronefarley@uky.edu, and that is Jerome with an N. If there's no more questions, John, you have anything?
No, just thank you to Rob for doing this really important session.
Yeah.
Thanks for having me, guys.
All right, it's a very important session in these unusual times that we are currently in. So I want to thank everyone again for joining, and be safe out there. And thank you again, Rob.
Bye, guys. Thanks.
Thanks.